Oral Health and Stroke, Series 10. Welcome to the Oral Health and Stroke presentation. I'm going to be speaking today about the relationship between oral health and stroke, stroke's impact on oral health, the implications of worsening oral health for the stroke survivor, and the importance of good oral hygiene. I will be recommending later in the presentation that you view some of our other webinars for additional oral health information. So, some statistics first about stroke. Strokes are the third leading cause of death in Canada. 80% of strokes are ischemic and 20% are hemorrhagic. 6% of all deaths in Canada are due to stroke, and each year more than 14,000 Canadians die from stroke. Surprisingly, more women than men, and each year about 15,000 people in Canada experience TIAs, and most of those go unreported. Many people who've had one or more TIA before their stroke, of every 100 of those people who've had a stroke, 15% will die. 10% will recover completely, but I want you to look at the box that we've outlined here because these numbers are most interesting to us from an oral health perspective. When you add up the numbers, that's about 75% have some degree of impairment or disability, and for many this includes basic oral hygiene care issues. 25% recover with a minor disability, 40% are left with a moderate to severe impairment, and 10% are so disabled that they require long-term care. Oral health and stroke. So what's the association between the two? As early as 1989, case studies were indicating a strong association between poor oral health and systemic diseases. The Heart and Stroke Foundation of Canada refers to several studies linking gum disease to a significant risk for myocardial infarction and stroke. Poor oral hygiene that leads to dental infections could contribute to adverse medical outcomes such as stroke. The Centre for Disease Control and Prevention noted that bacteria can contribute to gingivitis and periodontitis, provoke inflammation or infection which can trigger certain diseases, and periodontal disease may even aggravate or worsen those existing health conditions. So, infection involving the soft tissues of the periodontum and the pulp can firstly elicit an inflammatory response that could release a variety of biologically active molecules into the systemic circulation and could directly or indirectly then influence blood vessels. Or the other thought is that dental infections raise white blood cell counts and again elicit a chronic inflammatory response and or asymptomatic bacteremia that links dental infections to stroke and coronary vascular disease. People with periodontal disease are much more likely to suffer from coronary artery disease, stroke, than those without the disease. So the presence of gum disease may increase the risk of stroke. So the severity of the gum disease is correlated to the amount of plaque in the carotid arteries, and so there's a link between the atherosclerosis and gum disease. Other oral conditions are risk factors for stroke. Dental conditions such as missing teeth and edentulosinus, which is total loss of teeth, are associated with stroke and bacteria that reside on those teeth. Vice versa, the most common chronic systemic disease, stroke, in the elderly have numerous adverse oral sequelae such as aspiration risk, pneumonia, and mortality implications. A little more on missing teeth. Missing teeth is a significant risk factor for ischemic heart disease. And actually, we found that veterans who lost their bone structure around their teeth already in their 30s due to smoking were 2.8 times more likely to be diagnosed with a stroke than those who didn't have any bone loss around their teeth. And they also found that when you had missing teeth, so only 1 to 14 teeth were found in the mouth that this was significantly, again, associated with coronary heart disease. Oral health in young adulthood is independently associated with later life cardiovascular disease. So again, missing teeth is an index of oral health. 9 or more missing teeth at baseline, these people had increased risk for coronary vascular disease compared to those with 5 or less missing teeth. Stroke showed an increased mortality risk of 64%. So although the association has been established, we need to remember that the available evidence has not proven the causation between oral health and stroke.
So what are the effects of stroke? And we're specifically looking at this related to oral health. So the left cerebral cortex, what we're going to see in the person is right-sided paralysis and difficulty with the auditory memory, but also with speech, language, and the oral phase of swallowing. With respect to the right cerebral cortex, the person will experience left-sided paralysis and associated pharyngeal dysfunction with potential for aspiration and difficulty with memory and subsequently then performing certain tasks such as toothbrushing. The cerebellum, what we'll see here are some swallowing difficulties to paralysis with the potential for aspiration pneumonia. And finally, the oral facial motor and sensory impairments that this person is experiencing as a result of stroke can lead to improper dental and denture hygiene, and ultimately leading to dental and periodontal diseases and oral microbial infections. In the end, what we're looking at is a significant impact on the person's quality of life.
So what's the impact of stroke? The oral facial manifestations of stroke include a unilateral facial paralysis, so that could be complete or partial loss of motor or sensory function, and this can affect the upper or lower face, the tongue, and the soft palate. There could be paralysis of the tongue, mouth, lips, buccal musculature, cheeks, jaw, and soft palate, and can leave patients or residents unable to recognize that food remains in their mouth. So they end up with poor tongue function and an ineffective lip seal. Stroke-related oral motor impairment is very disabling, and any or all structures around articulation, speech, mastication, swallowing problems are common, do not always fully recover. This puts stroke individuals at high risk for dental problems. Limb paralysis and reduced manual dexterity are common physical features after having had a stroke. Manual dexterity affects the stroke survivor's ability to clean their teeth and dentures and to maintain a healthy oral condition. It puts stroke individuals at high risk for dental problems. Other health affects key aspects of daily living. So their oral functional disability in the medically compromised elderly has been shown to undermine not only their oral health related quality of life, but also quality of life in general. Medications, and especially multiple medications post-stroke for treatment, can impact oral health. Things such as antihypertensives, so this can be diuretics, calcium channel blockers, beta blockers, ACE inhibitors, and many more, can cause salivary dysfunction, gingival enlargement, mucosal reactions, and disturbances in taste. Anticoagulants can cause oral bleeding when they're brushing their teeth. And the medications themselves post-stroke can cause a dry mouth, ulcers in the mouth, and stomatitis. For those with swallowing difficulties, medications may be administered in a syrup consistency, and this is still concerning because it further predisposes them to dental decay. Medications and dry mouth are closely linked, but dry mouth can happen for other reasons. Xerostomia, or dry mouth, is a subjective sensation of dry mouth characterized by a reduction or complete loss of salivary flow, resulting in oral dryness and alteration in salivary composition. This can lead to problems with eating, chewing, swallowing, speaking, tasting food, and bad breath are commonly reported among those with dry mouth. It has also been implicated in an increased risk of tooth decay and the development of oral candidiasis. Dry mouth can induce rapid deterioration in oral health and greatly impair an individual's quality of life. Recommend you take a look at webinar series 11, Dry Mouth. Dysphagia. Some statistics on dysphagia tell us that it's present in 37 to 78% of new stroke admissions to hospital. 22 to 50% of acute stroke patients demonstrate aspiration. So the risk of developing pneumonia now increases threefold when dysphagia is present, and the risk of developing a pneumonia increases 11-fold when there's confirmed aspiration. 3 times greater risk of mortality with the diagnosis of pneumonia after stroke. Therefore, some of the secondary complications from dysphagia are quality of life issues, malnutrition, dehydration, and death, and of course, aspiration pneumonia. So a little bit more on aspiration pneumonia. Stroke and oral health have implications for aspiration pneumonia, and aspiration pneumonia is a very critical issue. Why? When somebody has had a stroke, they could have difficulty with dysphagia, which in turn can lead to increased difficulty or decline in their oral health. There's dependence often on somebody else for completing the oral care. The oral cavity bacteria can be the cause of the aspiration pneumonia due to the risk of pathogenic bacteria and fungi from poor oral hygiene and the aspiration of food particulates or fluid. Mortality becomes a complication factor, and it's important to remember that for persons who are NPO or to have nothing by mouth, that aspiration can still occur in those people. Brushing the teeth can reduce pneumonia rates by 50% and mortality rates by 50%. Oral health related quality of life. There are many issues or implications as a result of poor oral health on the stroke patient or resident's quality of life. Dentate stroke adults, so those are those adults with teeth, are at greater risk of dental caries and periodontal disease, as the plaque bacteria is the causative agent of both of these diseases. Edentulous people, so people with no teeth who have dentures, report difficulty cleaning their mouth and dentures. And the denture plaque can in turn cause infections and most commonly denture stomatitis. Some are dependent on their caregivers for their oral hygiene procedure, and many of these caregivers or even family who may be providing the oral care have little training on proper oral care procedures. There's the loss of oral sensation that may be of concern, but also oral pain, which can be an early indication of oral disease, which is often undetected in the stroke survivor. Pain from denture trauma, which can lead to ulcerations, and oral problems that may seem of great consequence in a person who is otherwise well, but may have less impact on a person's life if that person has greater problems affecting other areas of their body and their health as a result of stroke. In a study looking at the quality of life of stroke survivors, it was found that their quality of life was significantly impaired despite even being healthy enough to be discharged. 40% had problems with chewing and biting, 30% experienced discomfort during eating, 50% were not happy how their teeth looked, and 42% had problems speaking. In another study related to quality of life, they found that 37% reported difficulty cleaning their teeth, and 73% reported being unable to use one hand properly as a result of the stroke, poor grip, and totally unable to use their hand. They also complained of a painful, aching mouth. Oral hygiene needs. There are many for stroke survivors. And even during the stroke rehabilitation phase, oral care is often overlooked. Oral care can be a challenging task for those who have sensory impairment and loss of motor function. Physical weakness, lack of coordination, and some cognitive problems that can accompany a stroke may make it impossible for a person to maintain good oral hygiene on their own. Oral sensoromotor impairment may result in neglect of the oral hygiene on the affected side, and this predisposes them to dental caries, periodontal disease, and bad breath. They may also be confused and unable to recognize the use or function of everyday objects related to their oral care and their dentures. Post-stroke paralysis and facial muscles may lead to poor fitting dentures, which can lead to denture stomatitis. and choking risk. It's important to remember for even those who require tube feeding, their oral care is important, especially with feeding tubes, as oral muscular tension often prevent them from receiving appropriate oral care, but there still remain many of the other oral issues secondary to stroke. Also, orally taken nutrition supplements during the rehabilitation time can be cariogenic, meaning they can be high in sugar content and promote tooth decay. Oral hygiene promotion. Promoting a clean mouth. It's really all about a team approach. You need everyone involved in working together to prevent deterioration of the patient or the resident's oral health and reducing their oral risk. A clean mouth not only feels good, but the practice of oral hygiene, removing that dental plaque and traces of food, is a crucial factor in maintaining the health of the mouth, teeth, gums, post-stroke. A clean and healthy mouth will also prevent pain or discomfort and allow people to eat a range of nutritious foods, communicate, and socially interact. As in other aspects of post-stroke care, the rehabilitation goals aim to maintain and regain independence and should include to maintain and regain oral care skills. Promote oral hygiene best practices. That includes twice daily minimum oral care and, if possible, after meals and before bed, using proper equipment, fluoridated toothpaste, chlorhexidine gels if necessary, non-alcohol-based mouthwashes, discouraging smoking, eating non-sugary foods, and proper denture care for those who don't have teeth. Do regular oral health assessments to monitor their oral status. Remind them that harmful bacteria in the mouth causing problems with their gums and teeth could also be hurting their cardiovascular health. Make sure to ask if they brush twice a day and ask if they have dental disease. Just want to mention here that there are several webinars that have been developed that go into specific detail about how to do basic oral care, clean dentures, handle dry mouth and halitosis, assessment, and much more. We recommend that you check out webinars 1 through 7, 8, 9, and 11. The next two slides I'm not going to go through in detail, but just to basically note that the Canadian Stroke Strategy does mention the importance of oral and dental assessments and having good oral care protocols in place. Here's a list of the other webinar topics that I mentioned would complement this presentation, and we also have additional resources including best practice guidelines, articles, and various websites. Thank you.